Okay, good evening, everybody. Welcome to this 15th session of 51st Comprehensive Course on Echocardiography. I'm Dr. Rakesh Gupta from Jorap Institute of Echo, Ultrasound and Vascular Doppler, Delhi. This is our auditorium where you're likely to have your hands-on sessions. And these are legends behind this echo training program, starting from Dr. Karna Prashar, who has been the past president of Indian Academy of Echo and Cardiological Society of India. We have Dr. H.K. Chopra, who was a past president of CSI as well as Indian Academy of Echo, a very dedicated, dynamic person. Then we have our international president, Dr. Naveen Sinanda, who has published more than thousands papers to his credit. Then we have Dr. Samir Srivastava, who is a course director, and he's based as a non-resident cardiologist at Max Super Specialty Hospital at Saket, New Delhi. Then we have Dr. Hansa Gupta, who is one of the course director for these programs. She is based in Gurgaon, and we are going to hear her today for cardiomyopathy. When you have been contacting with these two people, Dr. Narang and Dr. Mrs. Reena Dua, many accreditation to these training programs, starting from Indian Academy of Echo, International Society of Cardiovascular Ultrasound, Alabama. We go to Delhi Medical Council for accreditations. Then we go to CDMO Northwest District for doing hands-on training permissions. We are running 1-year training program with Parul University, Vadodara. And last year, we helped BAPIO Training Academy to train their technicians in India who were subsequently absorbed in UK. We can boast of saying that we are the only institute in India providing hands-on training, and that's too from year 2000. We have almost completed 25-year glorious year in April 25 without any single break, and we are celebrating it on 17th August 2025. And this is what April 2000 we started its first basic training program, and this is 51st in April 2025. This course started on 9th April, as all of you remember, and those people who have opted for a hands-on session, now these dates are finally fixed. They are soon after Chhath Puja and Diwali, so all of you can book your tickets accordingly. And today we have a session on cardiomyopathy, and we have none other than Dr. Hansa Gupta, who is a vice president for Indian Academy of Echo and a very dynamic past secretary of Indian Academy of Echo. She is working at many places and just saw it at Paras Hospital and other places where she is working as on today. With these few words, let me have a pleasure of handing over mic to Dr. Hansa Gupta to start her deliberation, share her slides so that we can go ahead and see her presentation. Dr. Hansa, can you share your slides?
Yeah. Thank you.
Of echocardiography.
Yeah. Thank you very much, Dr. Rakesh Gupta. Thank you for the kind words. And I begin with cardiomyopathies without wasting any second moment. Welcome all of you. And I would, try at this point of time of the day when all of us had a busy day and had our food and everything. So I'll try that you all don't become sleepy. We'll try to communicate, and I'll try to make it more interesting for all of you from the practical point of view. Why is this not moving? Deepak, you need to help me. This is not moving. Just hold on for a sec. My screen has started. It has started. Yeah. Okay, so before we move forward, let us first understand what cardiomyopathies are. As the name suggests, this is a disease of the cardiac muscle, right? So do not get confused with anything. It is primarily a disease which we diagnose with the help of excluding other diseases. For example, rule out whether it is due to ischemia, due to valve disease, hypertension, or pulmonary heart disease. When everything is ruled out, then we label it as a cardiomyopathy. Remember, it is a disease of the myocardium primarily, all right? So as per WHO classification, we have dilated, hypertrophic, restrictive, arrhythmogenic right ventricular cardiomyopathy, and unclassified ones. So in the unclassified ones, we have LV non-compaction, which is now called as cardiomyopathy with excessive trabeculations. The other one is the hypokinetic non-dilated cardiomyopathy, wherein there's a lot of confusion in that, but you should at least keep it in your mind that there can be another genetic cardiomyopathy wherein the ventricle is not dilated yet hypokinetic. All right, so this is also a form of unclassified cardiomyopathy. So we start with dilated cardiomyopathy. Before starting this, I would just try to tell all of you that even though the patient has been referred to you for an echo, or you might be the treating physician of that patient, you must look into the ECG of the patient, take a brief history of the patient, because that will help you guide. That when you are looking at the findings, it will help you guide, because sometimes the patient comes as a referral, like the patient is having asthma. Then when the asthma does not get treated, the patient is referred for an echocardiogram. So this also present as a cardiac asthma, right? The dilated cardiomyopathy when the patient comes in heart failure. So generally, all the cardiomyopathies present as either arrhythmias or heart failure primarily. So taking history and looking at the ECG is very, very important. So this cardiomyopathy, the dilated cardiomyopathy, is characterized by dilatation of left ventricle or impaired systolic function, meaning the left ventricular ejection fraction, which we record, is impaired. It may be mild, moderate, severe, but it is impaired along with dilatation. Then we label it as dilated cardiomyopathy. And as I have already told you, it presents as heart failure with reduced ejection fraction, which in the early stages may be confused with asthma. In the peripheries, the doctors are not able to diagnose it. Okay, so I have just mentioned here the common etiologies which may lead to this dilated cardiomyopathy: idiopathic, familial, non-compaction. They all present as dilated cardiomyopathy, right? The postpartum cardiomyopathy you must have heard of. Infection-related post-myocarditis, viral myocarditis, this is very, very common. Toxin-related, in which the chemotherapeutic agents given for cancer treatment, post-alcohol, alcoholic cardiomyopathy, B12 deficiency cardiomyopathies, these are all presented as dilated one. And the Takotsubo cardiomyopathy, I'll touch it in little brief, okay, in the slides to come, but just have it in mind that what all can cause dilated cardiomyopathy. This is a video of the dilated DCMP. I'll be calling it as DCMP. So see, the chamber is so much dilated, and this is a severe LV dysfunction. I hope it is clear to everyone. So remember, this kind of picture is usually dilated cardiomyopathy. Of course, we will have to do an angiogram to rule out ischemia. See, this is the short axis showing severely dilated ventricle and reduced systolic function. Remember, these two things are very important for the diagnosis. Patient presenting with heart failure and this. Another important factor which I want to tell you is always find out what drugs, what medicines the patients are taking, because that may change the presentation or the clinical, this echo findings, because that will change the hemodynamics. If the patient is on diuretics or ARNI or other drugs, the improvement will be different. So ask him for the previous echo, and you will see, because echo is helpful not just in diagnosing DCMP, but it also helps us in assessing the response to the therapy. And in such kind of severe LV systolic dysfunctions, AICD, the defibrillator, is indicated. So your mentioning and your appropriate mentioning of the heart function, because less than 35% of ejection fraction becomes an indication for AICD, which is automated intracardiac defibrillator, because arrhythmias is a very important cause of sudden cardiac death in such patients. So it is important that you assess the ejection fraction properly. So now we come to other parameters which come in various stages of, which play an important role to assess the various stages, the ways in which the DCMP progresses. So this is a normal heart, all right? So you can see this length, the vertical length, and the horizontal width. Okay, so here the ratio is more than 1.6. Obviously, you can very well see the vertical length is more than the horizontal length. Now, what happens in this DCMP? This is quite an advanced stage. You will, often come across this kind of presentation of the patient, wherein the heart becomes very spherical and globular. So, can you see this now? So, the vertical is almost equal to the horizontal. So, this is a bad prognostic feature, because the remodeling is happening, and there is continued dilatation of the heart in the wrong direction. So the longitudinal and horizontal ratio is now less than 1.5. All right, so keep a because even with a virtual eye, this thing, first eye image of this thing gives you an idea that the LV is now very, very spherical. Now see this M mode. Okay, just first see, this is the anterior mitral leaflet of the mitral valve. Okay, and this is the posterior. So this comes like an M and this comes like a W, the posterior valve. All right, so just first see the M mode and now see this. So what do we call it as? EPSS. It is the E-point septal separation, and this is the mitral valve. Okay, and this is the interventricular septum. Basically, this is the M mode. Can you see here? The M mode cut across the mitral valves. Okay, so we measure this, the E point. This is the E point of the mitral valve, and this is the septal point. So this is generally less than 6 millimeter, and if it goes beyond 10 millimeters, then we say that there is a LV systolic dysfunction. Now, why does this happen? I'll show you in the next slide. See here. The septum is almost like the same thickening, which tells that it is not contracting. And this is the mitral leaflets. Okay, see this? And the chamber is dilated. So, of course, this distance will increase the chamber dilatation and the reduced systolic thickening. So what is happening? The EPSS has increased. So this is also a corroborative evidence. And generally in the busy labs, we do not do it because we are quite, now experienced to find out that yes, there is a reduce. But beginners, and sometimes when we are in a confusion, this thing EPSS measurement can certainly help you in establishing that yes, there is a DCMP here because of the dilatation and the systolic dysfunction, of course. Now, can you see this? There is this descending limb, you can see this bump. Okay, so this bump is generally produced whenever there is a raised LV filling pressures. So due to severe LV dysfunction, the pressures inside the LVs are high, and this kind of bump is produced due to incomplete closure of the mitral valve. So keep all these things in mind and don't underestimate the value of M mode. Always learn it. Sometimes the windows are not very good, that's different. But whenever you get a window, always try to put an M mode on the mitral valve. It sometimes, proves very, very helpful. Now see this. This is a M mode cut across the aortic valve. You can very well see on this Platt's view, right? This is very easy to do. In general, this is very easy to do. So this is a box which is formed here. This is a closure line of the aortic valve on B mode, and this is the aorta. And also see, there is a constant movement of the aortic valve with the expansion of the LA, because in the DCMP, there is also a reduced movement of the aortic root because the LA is not filling properly, or the LA pressures are very high. So the movement just becomes very low, and this kind of, wave pattern is not seen. Let me see if I have any slide on that. So here is a box which is complete. So this is normal. Now see this. It is here. So see this now, aortic root movement, which I said, reduced aortic root movement. I'll just go back. See this, the wave pattern, and now see this. So almost like, reduced, flat. Okay. The LA is also flat. LA is also not contracting very well. The LA dysfunction has set in. Why? Because there is a severe LV dysfunction. Severe LV dysfunction over a period of time causes LA remodeling as well. So with LA remodeling, LA dysfunction sets in, and your patient may also present with atrial fibrillation because of the dilatation as well as the arrhythmias, atrial arrhythmias. All right, and these are bad prognostic features. Your patient is likely to have more adverse events, more hospitalization, recurrent hospitalization, and he may go into recurrent failures whenever the LA is dilated, LA is dysfunctional, atrial fibrillation is there. All right, so all these things need to be noted. Now see what is happening here. The aortic valve is closing earlier because of reduced cardiac output, because of LV dysfunction, right? So see how beautifully this is shown here, and you can easily make it out on the M mode. This must have been taught to you, the cardiac output, but let us quickly revise it. This is the left ventricular outflow tract, all right, just before the aortic valve. All right, so leading edge to leading edge, measure it. The machine will give you the reading of about the area. Then put a pulse wave Doppler, not the CW, the PW. The pulse wave, you will put it just in the LVOT, around 1 centimeter before the aortic valve. And this kind of spectral trace will be obtained. So when you trace it, the machine will give you the time velocity integral. All right. So this will help you in making out what is the stroke volume. That's area into time velocity integral, right? And when you multiply this with heart rate, you will get cardiac output. How is this helpful in, why am I emphasizing it here? Because what happens is that when you follow up your patients, and even I'll tell you a tip here, because all this is little cumbersome. So what you can do is you can only measure TVI, right? So TVI is generally around 18 to 20. And what will happen in such cases of DCMP? It will be certainly reduced. So suppose it is 15 in some patient, and you start him on treatment. So on the first echocardiogram, you found that his VTI is just 15. So if that patient comes back to you again for a follow-up after the initiation of the treatment, you will again measure the VTI, right? And if the VTI improves to 17, 18, this means the cardiac output is increasing. Your medicines are working, right? So this is also helpful in the future follow-up of the patient and seeing the response to the medicines. Now, this is another, I have just put the slide here so that you can understand another concept of assessing the LV function indirectly with the help of mitral regurgitation if you get it in DCMP. So this is a mitral regurgitation jet, not very complete, but it is still, So I'll just tell you the basic concept here of measuring the DPDT, which will help us to assess the LV function indirectly. And so this is the 1 meter. Okay, so this basically assesses that in what time the pressure of LV reduces from 1 minute to 3 meter. In this, the time is calculated. So this time tells us what is the pressure inside the LV. If the pressure is high, then this value, generally it is around 1200, 1000 to 1200 is normal. When it goes less than 800, this says that there is a severe LV dysfunction. So when you will come for hands-on, we will try to teach you about this further. So DPDT is also assessed as a part of it. You calculate this, measure this and this, and the machine generally gives you the reading for DPDT. So just understand about this concept. The detail we will discuss later. Now coming to the diastolic dysfunction, because presence of diastolic dysfunction is also a bad, meaning if there is a severe diastolic dysfunction, that also tells us that the prognosis of such a patient is bad. So again, diastology will be dealt in a different class, but let us understand the spectrum of normal to abnormal, severely abnormal. Okay, you must be knowing about the restrictive mitral inflow pattern. Now, what are all these? These are when you put a pulse wave Doppler across, just beyond the mitral valves. Then you get a inflow pattern in which you measure E wave and you measure A waves, right? And you also measure the deacceleration time of E wave, right? You also do a tissue Doppler imaging in which you get E prime. All right. So basically, at least these three parameters tell us that whether the LV filling pressures, the LV and diastolic pressures, are they high? If they are high, it is a bad sign. So you will be measuring the E velocity, you will be measuring the A velocity, and this is all. How is it happening? This is happening by putting a pulse wave Doppler across the mitral valve. And so if it is more than 2, what does that mean? The E wave is twice the A wave. And the acceleration time is less than 150, right? And also the E upon E prime. E prime is what? E prime is the similar to E wave, the early filling phase, which is measured with the help of tissue Doppler imaging. So this all will also be taught to you separately, but just for now, understand this E prime comes with the help of tissue Doppler imaging. So this ratio, if it is more than 15, is bad. And if it is less than 8, you are at peace. Your E prime, if less than 7, is bad. Okay. So we need to figure out, you may not be able to, be doing the pulmonary vein assessment and everything on a daily basis in your echo lab. But at least these three things should give you an idea that E is more than 50, A is good, what is their ratio, what is the deacceleration time, what is the E prime. All right. So any E prime more than 7, you stay peaceful. But whenever this happens, your patient is not in a good state, believe me. Okay. So this is the reason I mentioned, because diastology will be altogether a separate topic. But for now, you should understand this concept, that we need to, this is not just simply to record the numbers. This is going to give you a good amount of information about the LV pressures. So whenever they are high, your patient is bad.
We have already dealt with the diastolic function.
All right. All right. So they must be aware about it.
We are already aware of it.
So ठीक है, this will be something like a revision for them, and the importance of, remembering it every time. So coming back to functional MR. So in this dilated cardiomyopathy, we generally get a functional MR. There is no problem with the mitral valves, but still MR happens, mitral regurgitation happens. Now, what is the reason? So here it is, there is the schematic diagram, which gray color is the normal. Okay, see this? So this was there earlier, this gray thing. Okay, see how the mitral valves are co-opting. There is a cooptation distance. All right. So the valves have to co-opt normally like this. But what happens in dilated cardiomyopathy? There is a dilatation. Now, this black color is the dilated ventricle due to remodeling. And the papillary muscles have also been pulled. So, what is happening as a result? The chordae are getting tethered. So, what is happening? This is causing the tenting of the mitral leaflets. And because of this, there is a tenting area under the mitral leaflets. So there is a non-cooptation, which is resulting into the regurgitation of the blood from the left ventricle into the left atrium. I'm sure I'm clear to all of you, because this is very important to understand. This ventricular remodeling leads to a lot of problems. And this, if this MR is severe, again, this is a poor prognostic feature in case of DCMP, because as an echocardiographer, as the treating physician, we should know, meaning it is just not performing an echocardiogram. We should also be informing the treating physician that these are the bad signs noted in your patient, so that the treatment can be instituted accordingly. Now see this, they are not co-opting well. Okay, it will be clear in the further images. This is the tenting area. All right, so normally 1 centimeter square. See, it's here, it is 2.6. So you will just trace it, and the machine, like you trace the mitral valve area, so you will trace it and you will find it, if it is higher than 1 centimeter square, it is generally high. See this? Okay, we generally don't calculate it, but yes, you should have a concept that what is it. So this is the tenting area happening because of the tethering of the chordae. Right. So this is the sum up of all the features of cardiomyopathy. You need to report the cardiac output, LV contractility, dimensions, rule out all these. Diastolic dysfunction reporting is very essential. As I said, it's a prognostic marker. Functional MR we just discussed, LA enlargement. There can be an associated RV dysfunction also. And the LV wall thickness is usually preserved. And increased EPSS, altered sphericity index, right? So I'll just quickly take you through these two cardiomyopathies which we commonly come across, and you should have an idea of what they are. So postpartum CMP also falls in the category of DCMP, and generally it is considered when you have following findings either in the last month of pregnancy or the first 5 months postpartum. So usually, remember, only 10% happen in the last month. Majority occur in the first 5 months postpartum. So there are 3 criteria: EF less than 45, fractional shortening less than 30%, LV end diastolic dimension more than 2.7 centimeter per square meter. So this they have actually mentioned as per the body surface area, right? And the TAPSE less than 14 also tells us about the RV systolic dysfunction, which is a bad prognostic marker. Coming to the Takotsubo cardiomyopathy, which we all know as broken heart syndrome, apical ballooning syndrome. So remember, it is due to excessive catecholamine due to excessive emotional or physical stress, some kind of acute sepsis. So here we have apical or mid-ventricular hypokinesia, akinesia, dyskinesia. And it is a complete mimic of ischemic heart disease. So you will have to actually take the patient for an angiogram, and when the angiogram comes normal, then we actually label it as a apical ballooning syndrome, which generally reverses in around 4 weeks. So I'm moving ahead, and it's generally very common in the postmenopausal women, and it is known to relapse in the future as well. So just these are the practical tips I'm giving it to you, so that you can suspect Takotsubo in your patients. So she's shocked, right? And see what is happening. So this is an octopus. This is an octopus catching pot. So the heart becomes like that, the apical ballooning. That is why it is called as, see, this is an octopus trap, Taka Subo. Just showing you some images. There's an apical ballooning and which reverses after 4 weeks. See this? Cannot be missed. Cannot be missed. See? And there is also a term called as reverse Takasubo, in which the basal, mid-basal segments, they become hypokinetic and the apex continue to contract well. So this term should also be there in your dictionary so that you do not become surprised that what kind of thing is happening here. All right. So let me, break here for questions, and then we move on to hypertrophic cardiomyopathy.
All right, Hansa, we can have a little break. Let me just ask questions, what they would like to ask about dilated cardiomyopathies. So you can raise your hands for any question which you like to ask. All right, Dr. Tajinder Kaur, please go ahead and ask your question and lower your hand.
Good evening, sir, and good evening, ma'am. Ma'am,
Good
kindly
evening.
explain again LV, DP, and DT.
Okay. So in LV, DP, and DT, you will measure the first point you will keep at 1 meter per second, right? I think I will need to.
Just show the slide.
Show me
slide.
It's more important.
Yes. Yeah. So see, the first cursor is put here, which is 100 centimeter, meaning 1 meter, right? And
Okay.
what is the pressure you are getting here? Gradient 36.
Okay, ma'am.
All right. And then you will keep another cursor here at 3 meter, right? 3 meter. So this we are going according to the border of the mitral regurgitation. This is the mitral regurgitation jet, this trace. All right. So we have put the first cursor here at 1 meter. The second cursor is put here, and this is the time we are calculating. All right, which is the DT. So this is the pressure change. What is happening here is that it generally takes 32 seconds to for the pressure to dip down. See here, to 32. This is the time which is taken for the LV pressure to drop down from 36 to 4. So how much fall is there? 32. Okay, so this generally happens normally. But when, and this is calculated like, the machine calculates, I don't remember the exact formula. There's a formula for that. It's shown here. So what happens is that when you measure these two things, the machine will give you a value. So which generally is around 1000 to 1200 millimeters mercury per second. The concept is that how much time it takes for the LV pressure to settle down. All right. So if the LV pressures are high due to systolic dysfunction, this pressure fall will be very quick. And so this value will go down. Here it is 711. So it shows LV dysfunction.
Okay, ma'am.
Did you get it?
Yes, ma'am. Yes. Ma'am.
So you will try it in your machine whenever you get an MR. Do it and try it, and you will then remember it. So this is basically how much, because every time the pressure increases during systole, you have to, and the LV has to drop its pressure to receive the blood from left atrium, right? The LV pressure has always to fall to receive blood from LA. Now, how fast it falls depends on the pressure which is already there. So if the pressure is high, the fall will be sudden. This is the concept.
Very simple answer is you just measure the drop of pressure over a period of time. Normal is about 1200. If it's less, it means LV dysfunction is present.
Yeah.
And machine itself give you everything. You don't have to do anything. Just mark at 1 meter, just mark at 3 meter, and look where is the marker over here, and the second marker at 3 meters. Look at the machine, drop of pressure over a period of time. And this is not used in clinical practice as on today. I can tell you that.
Okay, sir.
All right.
But
Any other questions?
yeah.
So let's move on to next person. He is Deepika. Dr. Deepika, go ahead.
Yes, sir. Good evening, ma'am. Good evening, sir. Ma'am, is reverse Takasubo similar to reversal of Takasubo? Like you said, it reverses after 4 weeks, but there is another terminology as reverse Takasubo.
Yeah. So in one of the Takasubos, which is the typical one, okay, the typical one is apical ballooning.
Yes, ma'am.
Okay. And I said it reversed after 4 weeks.
Yes, ma'am.
This term means it became normal. The apex became normal after 4 weeks, right?
Yes, ma'am.
So this is the reversal of the apical ballooning or the typical Takasubo. Then there is another entity like Takasubo, typical Takasubo, which is called as reverse Takasubo. Reverse meaning the apex is working and the basal segments are now akinetic.
Okay, ma'am.
Okay, so reversal is a typical English word, and this is an entity called as reverse Takasubo.
So, ma'am, do we need to treat in the reverse Takasubo? Treatment is required. The angiography, is it normal or not?
No, so again, angiography has to be done because this mimics ischemic heart disease, and your trop eyes will be high, your pressures, you may be hemodynamically compromised, because when you will do an echo, you'll find that this thing is dilated and non-functional. So what will come to your mind? You can't, you can't just leave the patient like that, because nowadays anything is possible.
Yes, ma'am.
So they can
both angiography will be normal in reverse Takasubo.
Both angiographies will be normal.
Okay.
Yes,
Okay.
yes, yes.
Thank you, ma'am.
And gradually you will see that these, because generally if there is a blockade and you don't treat it, it doesn't reverse. Very rarely it does also when the blockade, there is an acute, thrombus, and somehow it naturally dissolves.
Yes, ma'am.
Okay, but generally it's only in Takasubo where it is acute catecholamine which is suppressing the heart functions. They reverse.
There are two or three important things are there. Very high level of catecholamines, sudden onset, and the territory of coronary artery supply does not correspond to the wall segment abnormalities. Look at apex. Apex consists of LAD territory, but the basal anterior septum is also LAD territory. That is spared. If you go to reverse Takasubo, the bases are affected and apex is spared. So there's no correlation with the coronary artery disease territories.
Yes, sir.
Second is why we do angiogram. We can avoid angiogram, but in today's circumstances, we want to be sure that what we are dealing is Takasubo, because angiogram would be normal.
Yes, sir.
And then just medical management.
Yes, sir.
Okay. That's how this Takasubo cardiomyopathy comes into play in day-to-day practice. Many patients, broken heart means some family trouble, some husband trouble, some girlfriend trouble, some boyfriend trouble. Even I can quote an example where the lady was admitted for hysterectomy, and soon after hysterectomy, she went into Takasubo cardiomyopathies.
Yes, sir.
So you have to be very watchful. Mispresentation is like acute MI. Only thing is the territory do not correspond and angiogram is normal. It's a medical management. All right.
Okay, sir.
So let's move on to the next person, Dr. Lovedeep.
Good evening, ma'am. Good evening, sir. Ma'am, you said that when the suppose this DCMP patient, before undergoing any echocardiographic study, is started on some treatment, then would it alter the findings of echo significantly? And should we stop the treatment before undergoing echocardiography in such a patient who is symptomatic?
All right. So, no, the idea behind this was that we always follow up the patient, right? The idea was that ask the patient about the history, about any medications related which he's consuming, because what happens is, suppose the LV filling pressures were high, there was a restrictive mitral inflow pattern, you may not be getting a restrictive flow pattern now. Okay, so the MR may not be as severe because the diuretics have been instituted, the ARNI have been instituted, so the LV functions may not be that bad. But that tells us about the efficacy of the medications. So the idea is that you may say that, ma'am, the functions are not that bad. Maybe they have improved over a period of time with the help of ARNI. Maybe that the pressures are not high because the patient is receiving diuretics. So indirectly, this is that the medicines are responding. But if you will not know about it, your first parameter will be that.
Okay.
Okay, so you can always tell your patients that yes, you are improving.
Okay.
All right, that is the whole idea. No, nothing needs to be. Do not stop the medicines at all.
Okay.
All right.
Okay. Thank you.
Right, Dr. Kasim. Let's go ahead to next person, Dr. Kasim Ali. Please, Dr. Kasim, go ahead.
Good evening, sir. Sir, we have any other mean for to differentiate between idiopathic DCMP and ischemic heart disease, sir? Any other mean other than angio we can differentiate it, sir? Or we go for every patient for angio to differentiate to add antiplatelet, sir?
Okay, so what happens is that the ideal thing is that either you do a conventional angiogram or a CT angiogram, right? Because with this kind of LV, meaning if there is a severe LV systolic dysfunction, we will not like to subject the patient to stress ecos or TMTs, right? And so either we do a MRI, okay, cardiac MRI.
MRI.
So CT angio, conventional angio, because you need to figure out that what is the cause, right? But at the other end, I would tell you, because many of you are working and practicing in the remote areas, and the patient's financial condition also does not permit it. In those situations, you can directly, meaning after explaining to the patient and the attendants, you can straight away start with the 4 pillars of the heart failure therapy. Right? Ki bhi humne we gave ARNI, we gave mineral corticoid receptor antagonist, beta blockers, right? And what is the 4th one? SGLT2 inhibitors. Right? So we will start all these 4 drugs. If the patient has no access to cardiac MRI, no access to angiography, and of course there is a financial crunch. Right? You start with it. And they would know the attendance, so there will be no medical legal problem. But if these facilities are available, it is mandatory and the right way to proceed in the treatment. Okay?
Thank you.
Dr. Kasim, this is a basic course.
Yes, sir.
We have an advanced training where we talk about how to differentiate ischemic versus dilated cardiomyopathies. There are 2 factors which makes a difference. You do a tissue Doppler imaging S wave in dilated cardiomyopathy. So once you do a tissue Doppler imaging S wave in dilated cardiomyopathy, they'll be uniformly reduced all across in DCMP. And they'll be variable in ischemic heart disease. Second is you do a GLS of these patients.
Yes, sir.
If you do a GLS, this also be uniformly reduced in dilated cardiomyopathy.
Yes, sir.
Third important point is if you have an associated right ventricular which is also hypokinetic, the fair chances are we are dealing with dilated cardiomyopathies.
Yes, sir.
That's how we differentiate.
Yes, sir. Yes, sir.
That's how we differentiate suspect in ischemic versus dilated cardiomyopathy.
Sir, if we add empirically, sir, antiplatelet, there is no harm for patient.
I'm coming down to that.
Yes, sir. Yes,
next answer is you treat them. You give them antiplatelet, you treat them. First time once you see a patient, all patient, whether they are ischemic or dilated, there appears to be a dilated cardiomyopathy. Once you treat them, what will happen? The which are because of dilatation, they'll start coming back, and the segments which are not because of a dilatation, they'll start lagging behind.
Yes, sir.
So you
Yes, sir.
start clearly seeing dilated versus ischemic cardiomyopathy.
Still. Yes, sir. Yes, sir.
And finally, gold standard, as Dr. Hansa said, I'll not go for a CT, I'll not go for anything else. I always say, let's go for angiograms.
Yes, sir. Yes, sir.
Because angiogram consists of a less amount of a dye.
Yes, sir.
Because dye is in my hand, 10 ml,
Yes.
20 ml.
Yes, sir.
Second is quick. How many
Yes, sir.
seconds? 10 minutes. And the
Yes, sir.
most important thing is, if the person has got an occluded artery, CT will not open the occluded artery. It's the
Yes, sir.
angiogram where we can do an occluded artery can be dealt with.
Yes, sir. Yes, sir.
So my question is, if you have a patient, treat him like a ischemic or dilated. That does not make any difference. Only difference is whether you are using antiplatelets or not, or
Yes, sir.
atorvastatin or these statins or not.
Yes, sir.
Otherwise, management remains virtually the same.
Same. Yes, sir.
And that's
Yes.
how we treat in our lab.
Yes, sir.
Every patient will not go for angiogram.
Yes, sir. Yes, sir.
Okay.
Yes, sir.
Any other question by anybody before we move on to hypertrophic cardiomyopathy? Dr. Muzaffar, you wanted to ask some question, then you withdraw yourself.
Yes, sir. Good evening, sir.
Good
The
evening.
question was same regarding because nowadays we see more of a coronary artery disease and ischemic cardiomyopathy. So I just wanted to know what is the role of that dopamine stress test? Do we still use it?
Yeah, we still use that. And if you have a patient who is having an ischemic cardiomyopathy, then why do you want to use a dobutamine? Just look at a paper published very recently, Relevance of Viability in Cardiology. Go to Journal of American Heart Association.
Okay, sir.
This has no relevance. So my question is, if you have a ischemic versus dilated cardiomyopathy, please take up these subjects for angiograms and get their angioplasty done so that we can recruit the muscle which is viable.
Okay, sir.
All right. So,
Thank you, sir.
all right, let Dr. Hansa move on to a very important topic, that hypertrophic cardiomyopathy. And it's become more important ever since the drug is getting introduced in India.
Yeah, correct. Now, why has this stopped moving? It's not moving.
Just click on a slide and then they'll start moving.
Okay, okay. Yes, you're right. Thank you. That's why I want you to be here. All right. So, friends, before we move ahead with, the eco features, I would like you to understand that there is always a gap in the diagnosis of hypertrophic cardiomyopathy, because unless until we have it in our mind that what is it and what can it do and how does it present. So remember that it is not very uncommon, because if you will start looking at it, you will find that, see, it is the prevalence is in the tune of 1 out of 500, which, if you will try look into it, you will keep coming across such kind of cases. So always keep in mind that this is not a rare thing. Then this is an inherited cardiac disorder, autosomal dominant, which means your 50% siblings are going to get impacted. Right? So if there is a person whom you come across, always try to find out in the siblings that whether there was a history of sudden cardiac death or such kind of issue. So you will always seek a family history in such kind of cases. Okay. And also remember that this is a commonest cause of sudden death in the young adults. So, of course, whenever there is a family history of sudden deaths, always remember that something of this kind may be present in the siblings, and the other siblings are bound to be suffering from it. And so that is why as I said before starting the cardiomyopathies, always look into the ECGs, because the hypertrophic cardiomyopathies generally will have one or other non-specific repolarization abnormalities. I would like to, I might be having some ECG related to this. So always remember, because sometimes we tend to miss, because you will have to really look for it, because certainly apical cardiomyopathy is bound to miss, regional segmental hypertrophy bound to miss, if you do not have in your mind that such thing exists. So ECG, looking at the ECG is very, very important if the patient has. So what is the clinical spectrum? The patients may again present with, generally you will find these patients to be asymptomatic. They will come to your office for an ECG, for a routine health check, and the ECGs will found to be having non-specific, a lot of abnormalities, and hence they will be referred to you for an echocardiogram. So there may have been normal longevity. They may present with atrial fibrillation because of the diastolic dysfunction of the atria, as I just mentioned. Then they can have sudden cardiac death, which is the most important worrisome thing. And of course, the heart failure, right? Now, how do we define hypertrophic cardiomyopathy? This is a very important slide. Do not miss it. See it carefully, listen to it carefully. Unexplained LVH with non-dilated ventricular chambers in absence of another cardiac or systemic disease capable of producing the extent of hypertrophy seen in the patient, meaning there is a disproportionate hypertrophy. There's no hypertension, no aortic stenosis, no other disease, yet you're finding a significantly thick left ventricular wall thicknesses, maybe some other segmental thicknesses, right? And if it is more than 15 millimeters, it is a compelling feature of hypertrophic cardiomyopathy. So remember this value of 15 millimeters, and there is no other reason for which can explain that this hypertrophy is due to what. And then go back, if you are finding such things, ask for the family history, ask about sudden cardiac death in the family, see the ECG, or if the ECG is not there, get an ECG done. Now, what are the echo features? This is again a schematic diagram which is beautifully explaining everything. See all the muscles. So this is basically a concentric one. Okay, there is a vast spectrum of hypertrophic presentation, and I'll explain it to you in subsequent slides. But for here, it is a concentric. The entire muscle mass is thickened. Now see this. This is posterior mitral leaflet, anterior mitral leaflet. What is happening? This is being pulled towards the septum, narrowing the LV outflow tract. So this is called as SAM, or systolic anterior motion of the mitral leaflet. See, this is the chordae also. The chordae is also getting pushed towards this side. Mid-systolic fluttering, because the obstruction is happening. So the atrial valves are also fluttering, right? The systolic, this I've discussed. Then diastolic LV dysfunction sets in later stages. The LV cavity, you see, it's normal or maybe reduced, but it is not dilated. And this systolic anterior motion leads to, because then there is a non-cooptation. So there is a mitral regurgitation. And this mitral regurgitation is posteriorly directed. So this is the anterior part, this is the posterior part. Okay, this is a posterior wall. So this is a posterior. So whenever this jet hugs like this, it is a posteriorly directed. When it goes towards like this, it is an anteriorly directed. Now, since SAM is happening, so generally you get a posteriorly directed mitral regurgitation. So all these things, because as I'll be telling you soon, that not just hypertrophy, there may be a problem with the mitral apparatus as well. This anterior mitral leaflet may be very elongated. There may be an abnormal insertion of the papillary muscles. There may be a papillary muscle which may be directly getting inserted on the anterior mitral leaflet. So there are a lot of problems with the mitral apparatus as well. Okay, so everything has to be noted and seen and reported. So as I will show you in my slide, the reporting of this HCM is very essential. Proper reporting, because that will help us in the treatment. So what are the classical features? As I told you, cutoff of 15 millimeters. Then in asymmetric, you have ventricular septum upon posterior wall ratio more than 1.3. LVOT again is very narrow in such people. It is around 20 millimeters. So that also increases the gradients, right? SAM of AML, I said, normal LV systolic functions in the beginning, and later on you may have reduced functions also. Diastolic dysfunction, then there is a dynamic LVOT obstruction. When do you get a fixed obstruction? Whenever there is a membrane, there is aortic stenosis. So those obstructions are fixed obstruction. But here you get a dynamic obstruction, which are preload, afterload dependent, or the size of the LV cavity, right? So that is called as dynamicity of the LVOT obstruction. So along with the left ventricle, right ventricle may also be hypertrophied, and similarly there may be an RVOT obstruction. Now let us see one by one. So this is left ventricular hypertrophy, asymmetric. You can see the posterior wall and compare it with this. So this is very, very clear. Okay, and also remember, basal posterior wall is relatively spared. IVS is generally involved more than as compared to rest of the myocardium. So what is the commonest type of presentation is generalized, okay, but other patterns can also be seen. I will just show you with the help of some videos and images. See this here, the septum, the anterior wall, okay, this septum, then this is the apical one. I'll show you with the So here only IVS is involved. See here in the short axis. Also remember, whenever you are measuring and seeing this, try to measure in the plaques view as well as the SACS view, right? The measurement is very, very important. You will soon come to know, because the thicknesses are important to be measured very, very carefully, as they are, a very important marker of the prognosis. So next. So this is the inferior wall. You're not finding other segments. So don't be amused and amazed that just the inferior wall is hypertrophied. What is this? No, this is a spectrum of hypertrophic cardiomyopathy. See here, only the interior wall. You're finding it in the short axis very, very clearly. So just bring it into your mind that any single segment may also be involved. You must be having an idea that generally it is concentric or it is asymmetrical. Beyond that, the things might have not come into your mind. So briefly, let me just tell you that where else you can get asymmetrical septal hypertrophy other than hypertrophic cardiomyopathy. So I think I'll show you some. So you know, you often get the abnormalities of the basal septum. Okay, you may find a sigmoid septum, which everyone must be coming across while you're doing echoes. The sigmoid septum appear like a hypertrophic cardiomyopathy, but it is not. Then LVH of hyper elderly, this I will show you. The cardiac amyloidosis is basically a hypertrophic mimic of HCM, but it actually falls into the category of the restrictive cardiomyopathy. Remember that, because in amyloidosis, there is no hypertrophy. Here, there is a hypertrophy of myocytes. But in this, there is no hypertrophy. It is the deposition in between the myocytes of amyloid material. So this was the thing. You know, you have a posterior wall MI. So this has relatively thinned out, and so it is appearing thick. But no, I think it is wrong. This is looking thick. Okay. So, but yes, instead of concentric, it has become asymmetrical. Now, another important thing is you get a lot of trabeculations in the RV. Not very well seen here, but this is very clear, measurement. So while you are measuring your this thicknesses, do not include the trabeculations or the moderator band, because else that will give you a false measurement, and you will falsely measure it high. So this is like, spontaneously closed VSD, because of which it is looking thickened here, but this is a small VSD closed with the fibrosis, so appearing like that. This is HCM of Adler-Lee. Now, this again we will discuss because I'm coming it one by one. Now, what is systolic anterior motion of AML and why does it happen? So again, listen to it very carefully, because this is very, very important to understand. It is the flow drag, pushing force of flow, which is the dominant role. Okay, the blood flow pushes, drags the anterior mitral leaflet. The Venturi effect is minor. AML is most often elongated, as I have just said. AML and PML both participate. It is not just that AML alone is participating. Sometimes there are elongated chordae, which also prolapse in the LVOT. And also then they pull the AML along. And then there is an anterior displacement of the papillary muscle, which also falls into the LVOT and sucks the anterior mitral leaflet. Septal hypertrophy causing the redirecting ejection flow. The severity, there is a severity grading. So here, instead of cramming all this, just remember this 10 millimeter value and the systolic value. So what does 10 millimeter means? If it is going very near the septum, so the distance is less than 10, so it is becoming more severe. It is bad. If it is happening in more than 40% systole or holosystolic, it is again bad. Just remember that. So the duration of the systole for which the SAM is lasting, or how wide the SAM is, which I'll just show you with a, I'll be soon showing that to you. But understand this LVOT obstruction, it's a dynamic one happening in mid and late systole. SAM and mitral septal contact are responsible, narrow LVOT, caudal apparatus prolapse, or abnormal papillary muscle insertion on AML. All these lead to the obstruction. Now, how does the obstruction looks like? A Turkish dagger, onset after the QRS. I'll tell you with the example so things will become more clearer. Jet is narrower. Obstruction is maximum in late systole. Contour is concave to the left. Larger and longer is the SAM. Significant is the obstruction. And to find out the maximum extent of obstruction, apical 3C view is the best view, because the spectrum, you can put the Doppler as parallel to the flow. So you will get the best spectrum in that. All right. And the differential diagnosis of LVOT jet is with the MR jet, and so avoid overestimation. Now let's understand. This is a case of SAM. All right. So what we have done is we have put an M mode across the mitral leaflet. Okay. So what is this? SAM means systolic anterior motion. So this is the systole, right? And this is the mitral opening. So this is the, so during the systole, the mitral valve should not move towards the septum. It only happens in the diastole. All right. So see here. So this is the distance which I'm talking about, 10 millimeters. All right. If it is less than 10 millimeters, it is bad, meaning it is severe SAM and it is lasting for quite some time. Right. So this is the concept of SAM measured with the help of M mode in the plaques view. So you will see the duration. and the extent. 10 millimeter, remember that? And the extent, more than 40% of this stole is severe. Okay, so this is a narrow LVOT. We'll see further. See the turbulence here. Okay, so this turbulence is because of the obstruction. Now see this. Typical dagger shape. Chaku ki tarah. Late peaking gradient. And concave, I said, na? So in the next view, I think, yeah. So see this concavity. And this is the aortic stenosis. So whenever you will always, whenever you'll put a pulse wave Doppler, you will hear a swish, and these kind of dagger things are coming. It may also happen in an hypercontractile LV when there is a tachycardia. But whenever this is happening, always, raise your ear and eyes, open your eyes to look for any obstruction in the LV cavity. This is a rounded thing. Okay, this is the aortic stenosis, typical rounded aortic stenosis spectrum. See this after the QRS starting, because this is important. In the next slide, I'll show you again after the QRS. So both LVOT gradients and aortic stenosis spectrums are seen after QRS. Wait. So again, this is a LVOT gradient. You can see a lot of turbulence here. See this? So do not forget such kind of, the gradient of 41 is obtained here. Such kind of obstructions and spectrums, don't miss them. See this? This is a provoked gradient. So it went up to as high as 82. So it will come, the MR thing. Let me see. Okay, so how do we assess the LVOT gradient? So as I said, you will use PW to localize the site, because you may get a gradient in the mid LV cavity also. You may find it lower down also. So to localize which is the area where you are getting maximum, you will first do with pulse wave. Then for measuring the maximum gradient, you will use a continuous wave Doppler, because if it is very high, you will start getting aliasing spectrums, tracings. All right. So use CW, and that will help you get the entire trace. So measurement is performed at rest. And if gradient is not very high, generally less than 30, we will always try to provoke it. Never send your patient back without provoking the gradients. This will be a crime. So you may be busy, whatever it is, you have to provoke the gradient. So generally doing a Valsalva or making the patient simply stand. So all this is reducing the preload. So what happens when the preload is reduced, the LV cavity will further narrow down and the gradients will increase. That's the whole idea. Some people use sublingual nitrates also. I don't do that for the risk of sudden hypotension or some increased a gradient, patient may go into syncope. So I generally prefer doing Valsalva or standing. Standing is also a pretty safe and a simple thing to provoke. So as I said, reduce preload, reduce afterload, volume is reduced, LV contractility whenever is increased. All these things will increase the gradient by increasing obstruction. This we have seen. This also we have seen. Effect of provocation. Now, again, have a good look at this slide, because it is very important to see, because anything, a gradient at rest more than 30 millimeters mercury holds a bad prognosis. And we also have to subject such a patient, if the gradient is more than 50, we subject the patient to some kind of procedure. So now this nomenclature is very important, because when you will make a report, you will have to write this is a hypertrophic obstructive cardiomyopathy or a non-obstructive cardiomyopathy. Just a second. So remember this. you're getting it at rest and at provocation. So this is an obstructive one. Okay. Now the one which is less than 30 at rest, more than 30 on provocation is a latent, meaning hidden HEVO. It is hidden and is called as labile hypertrophic obstructive cardiomyopathy. The one wherein you do not get at rest and neither on provocation, this is a non-obstructive one. So you must remember this 30, the figure of 30, and after provocation, before provocation, and what is the nomenclature used. Because without this, your report will be incomplete. Now see this. The LVOT is very, very clear. Good sized. There is no SAM. See, the mitral valve is not moving towards the septum at all. Okay, so this is a very clear non-obstructive. We'll put a color here and see. It is smooth. There's no significant turbulence seen across. So this is how you need to see. Put a color, see it on M mode, B mode. All right, that there is no obstruction. Now, the most important differential is with the hypertrophic, this concentric hypertensive heart disease. All right, so in this, I would just say that find out the history. You will not have, except for some increased voltages, you will not have repolarization abnormalities. The hypertrophic is usually symmetric and involves the basal posterior also, because this is what you will commonly come across in your clinics, that the patient might be having hypertensive heart disease. Is it that, or is it hypertrophic, genetic hypertrophic cardiomyopathy? Hypertrophy usually symmetric, involves basal posterior. Diastolic dysfunction sets in early, which is not in the case of hypertrophic cardiomyopathy. And once you give a tight control of to systolic blood pressure, the LVH regresses in 6 to 12 months, which is unlikely in HCM. Okay, athlete's heart is also another very important entity, which you should keep it in your mind. We tend to forget, but then always remember, take the history, and you will find that the person is doing the exercises vigorously. There is a symmetric hypertrophy with a dilated ventricle. There's no diastolic dysfunction, and it regresses after stopping exercises for a few weeks. You can take a history of strenuous exercise. So we should differentially diagnose this entity. I skip this. I also remember that whenever there will be a hypovolemia, or you are giving dobutamine during the dobutamine stress test, so these are the causes which also lead to increased LVOT obstruction, but those are pseudo ones, which will get corrected automatically as the cause is corrected. This I've already mentioned. So now we are coming to MR, which I explained it to you earlier. See this now. Okay, this is basically MR. And there is a double image of the LVOT gradient also within merging in it. But you need to differentiate that what is what. So the MR generally starts within the QRS. All right. And the LVOT gradient starts after the QRS. See this. And what is the difference? So we have very high gradients in MR, and it is appearing within the QRS, and steep boundaries here. This is concave, right? And you have a smooth boundary here. So differentiate, because both of them fall. You are seeing here, when we are putting a cursor here, CW, it will catch everything on its way. So there is an MR also, there is a LVOT gradient also. So both are coming in the same spectrum, same trace. So do not get confused with it. Now coming to another important component of hypertrophic cardiomyopathy, which is apical, in which the hypertrophy is limited to the apex of the heart. So this thing is, this entity is something which is very commonly missed by most of the people, because the apex in such cases, when you have apical HCM, the apex is not very well visualized, and you will find that whenever you're trying to make 4C, the apex is quite obliterated, not seen very clearly. So you should have a very, very high suspicion when you are getting a typical ECG pattern of deep T wave inversions in precordial leads, also called as Yamaguchi syndrome. So I have seen them, a lot of people, lot of, good doctors at good hospitals missing on this, because everybody is in a hurry, and this apex is not very well visualized if you don't try to make it more prominent and use other ways out. So that's why I'm emphasizing, whenever you see a patient with this kind of ECG, always bring into your mind that there is a possibility of apical HCM. So the LVH may be difficult to pick unless careful. There is no LVOT obstruction. The apex may be hypokinetic, but there'll be no history of ischemia or any other associated finding. So this is not very well visible. Again, you may again be confused with endomyocardial fibrosis, in which the cavity is obliterated. So it will be kind of roundish thing. Okay, but here it will be a clear apex. Put color flow across it, and you will see that there is a spade which is being formed. Okay, the spade of the playing cards, or you know about this spade. So it is such a prominent V made here because of the thickening just in the apex. Okay, so once you will see a case, you will never forget it. Try to put color Doppler, and you will see that the color Doppler is making a line here, which is usually not the case. So you will try to put color from tomorrow in a normal left ventricle, and you will see how it looks like. Okay, so whenever it will not look normal, something will go into your mind that apex is not normal. So when apex is not normal, bring three things into your mind. Is it an apical hypertrophic cardiomyopathy? Is it endomyocardial fibrosis? Or is it ischemic hypokinesia of the apex? Only as Dr. Rakesh has just told you all, that LAD territory when involved can cause apical involvement. Okay, so these three things, but in that ischemia, you will not have hypertrophy. Yes, in a hypertensive heart disease, if there is an hypokinesia, it will again mimic like that. So these are the general practical tips I'm giving you when you come across, when you are doing echo in such patients, right? So always relate your echo findings to the clinical scene, clinical scenario. Okay, don't just try to be like a machine which is doing an echo, writing the findings. You will also have to see that what is happening, it is not corroborating with the ECG. So something is there. So do not omit. Try to make a good apical view always, wherein your apex is clear. And also remember that when apical cardiomyopathy is there, visualization of apex is very difficult. I'll just show you some cases, I came across because they were missed. And when I saw the ECG, I could not forget. And I really digged into it. And there was a kind of, small aneurysm also. I'll just show you. See this, in this view also, they have put the color Doppler. It's not going very well, just a little portion that it is going into. So using contrast is also another way, but contrasts are expensive. No, not everyone is used to it, and not commonly practiced in the small places, right? So, but then that is one of the ways. When you put a contrast, you will get a very, very classical apical spade, which is very, very diagnostic. And the other thing which helps you is cardiac MRI. So if you are confused, if your ECG is not matching with your findings, always order a cardiac MRI for your patient, even if he has to go to a faraway place to get it done. So coming to another entity, so these are, the most important, most commonly encountered. the concentric one, the apical one, and now the mid-ventricular one. So just the mid segments of the left ventricular are involved disproportionately, may be associated with an apical LV aneurysm, and you may get a LVOT gradient in the mid cavity. See here, nobody can miss this. See here and see this. Classic. And here when you will put a pulse wave Doppler, you're bound to get a gradient. See this? And gradually, since the blood keeps getting trapped here because of this obstruction, so this apical area starts ballooning out, and that's how an aneurysm forms. See the turbulence here. And again, you know, the pulse wave Doppler was put here, and you can see the dagger here again. So now this case I want to show you, because see the extent of concentric LVH. You can get such kind of cases. Enormously hypertrophied, asymptomatic patient. Just the ECG is revealed atypical symptoms, and ECG reveal a lot of repolarization abnormalities. See this short axis view. There is no SAM here. Okay, despite of so much of hypertrophy. See this? The LVOT is not so narrow. So it is nothing strange that with such a hypertrophy also you're not finding SAM. Good for the patient. So the GLS is also normal at the moment. So this is telling us, we can wait, because the MRI also did not show much. So there are such kind of, confusing situations wherein the treatment is very, very confusing. But yes, as an echocardiographer, you need to report all this. Now see this ECG. You can see the deep T wave inversions here. Now see this. This was an apical cardiomyopathy. Can you see something aneurysmal here? However, when I got the MRI done, the MRI did not reveal any aneurysm. There was only apical cardiomyopathy, and there was no gadolinium enhancement, and so the patient was not offered any kind of AICD. See this, deep T wave inversions. Can't be missed, and they don't look ischemic. See this, generalize this, and in the anterior lead, such deep T wave inversions. Now keep this in your mind, store this in your memory, so that you never miss on to apical hypertrophic cardiomyopathy. And you will keep getting these kind of, pictures if you really want to look into it, that what is the ECG like. And now another important, information about this, the screening of the family members. Now, once this is done, it is your responsibility and your prerogative to tell the attendants that all first degree relatives to be screened at least once. If there is no HCM at the first stage, then in children between 12 to 18 years of age, it should be done every year. And after 18 years of age, it may be once every 5 years, because sometimes the HCM or the hypertrophy happens later on. So you may miss, you may think that it is not there. So till 18 years, because it has been found in various studies that after 18 years, it becomes relatively uncommon. So this is how you need to follow the screening protocol. And as a doctor, you should know and remember that such family members need to be very, very carefully screened. At least you should be telling them. Whether they go ahead or not, it is their thing. Okay. So these are the echo predictors of unfavorable outcome. Now this value of 30 millimeter is the maximum wall thickness of any segment, meaning one single segment of the left ventricle even if one segment is more than 30 millimeter, the chances of sudden cardiac death is very, very high. LVOT gradient more than 30 millimeters, I told. Ejection fraction as just down by 5%, but it is important. It is bad prognostic marker. LA diameter, LA volume, meaning the moment LA dysfunction and LA dilatation starts, it is a bad prognostic marker. So you should be looking for all these parameters and mention it carefully. So your echo reporting should mention the maximal wall thickness, the SAM present or absent, the LV-OT gradient at rest and provocation, and MR severity. Without this, your report is incomplete. So just knowing the echo findings is not enough. A proper reporting is also equally important. Right. So, Dr. Rakesh, can we have questions now?
Yeah, we'll have a break for questions.
Yeah.
If you would like to ask the questions, please go ahead and raise your hands. Well, whenever you see abnormal wall thickness, look at that wall thickness, why that wall thickness is high. Anything more than 15 millimeter is abnormal. Look at an ECG, correlate clinically, and then you'll have an answer why my patient is having a significant left ventricular hypertrophy. And it could be with obstruction, it could be without obstruction also. So hypertrophic obstructive cardiomyopathy, hypertrophic non-obstructive cardiomyopathy, which people often write as HCM. So any questions from any side before we go ahead with restrictive cardiomyopathy? All right, Hansa, I think there's one. Dr. Qasim Ali want to ask the question.
Yes,
Qasim, go
sir.
ahead.
15 mm, sir, in diastole, sir, maximum.
Always in diastole, never in systole, man.
Yes, sir. Thank you so much, sir.
Never in systole.
Yes, sir.
Qasim, what happens is that while you are in diastole, okay, what happens in diastole? The LV is receiving the blood, and you just remember maximum you will go into when the LV is in the maximum diastole. Okay,
Yes,
because in systole, anyways, the muscle contracts. Okay, so it will automatically become thicker. So whatever has been studied, and the 30 millimeter is in the diastolic thing. Okay, so when you measure the septum and the posterior wall, what do? You calculate 8 millimeters and 12 millimeters. So what is 12 millimeters? 12 millimeters is systolic thickness.
Systole. Yes, ma'am. Yes, ma'am.
So it becomes 4 millimeter thicker.
Yes, ma'am.
So never in systole.
Yes, ma'am.
Right?
In diastole. Yes.
Yeah. So shall we move to restrictive?
Definitely. Please go ahead.
Right. Okay. So again, before moving ahead, restrictive cardiomyopathy is also very extensive. I'll practically tell you that when do you suspect that this is a restrictive cardiomyopathy, and we'll talk about amyloidosis, right? Because these are two important things. And also that, we differentiate restrictive cardiomyopathy with constrictive pericarditis, right? So you must have heard about the restrictive physiology, right? So now see, what is the definition? An idiopathic or systemic myocardial disease. Remember, cardiomyopathy is a myocardial disease having restrictive ventricular physiology in the presence of, meaning you will find that the LV is functioning normal. The volumes, the dimensions are not increased, the LV dimensions, and yet there is a restrictive physiology, right? You will wonder, what is this? Then look at the atrias, right? You will find that both the atrias are dilated. Patient's ECG might be showing atrial fibrillation, okay? And you will find that rest everything is okay. Then, and the patient has presented to you in heart failure. You are finding that IVC is dilated, pulmonary artery pressures are high. What can it be? Okay, so then you will start excluding and you will start thinking that what is it? So that's where restrictive cardiomyopathy comes in. What is I'm just repeating it again. Normal LV functions, apparently normal LV functions, normal thickness, normal ventricular volumes, dilated, both the atrias are dilated, and there is a restrictive physiology. Because generally you will find that, there's some impairment of systolic functions, then where we get restrictive physiology. So whenever this kind of presentation is there, the patient comes to you in heart failure and you are finding all this, keep this identity into your mind. Okay, see this, I told you, a very, very tall E wave. Okay, another point I would like to tell you here, because I also made this mistake at my young age when the diastology was not all that, routinely used. So what happens in young patients, you will get this kind of pattern, okay? Because in them, the LV is very, very compliant and there is a very tall wave. The A wave is not that tall. So what will happen? This thing will reverse. So do not be mistaken with this kind of pattern in a young individual, and do not label it as a restrictive physiology. This tells about the fact that the LV is very, very compliant and the E waves are very tall because there is a quick fall in the pressure. Got it? So, but coming back to the point, this just came to my mind and I thought, let me tell you here that don't commit this mistake. And so in this kind of restrictive cardiomyopathy, you have an extreme form of diastolic dysfunction, right? And see here, another important tissue Doppler imaging you will find that because this is a primary muscle disease, okay? So all the velocities are reduced. The systolic velocity, see, this is normal. See, this is the E prime, A prime. What has happened? All of them are suppressed. Okay, so since the muscle is diseased, stiff, so this is what is happening. Your tissue Doppler velocities, all the velocities are reduced. So this is an extreme form of diastolic dysfunction. What is happening? Small, thick-walled ventricle, normal systolic function. Now see this. Both of them are dilated. There is a TR, abnormal diastolic functions. And there is an impedance to LV filling pan-diastolic. Why have I written this pan-diastolic here is because the muscle is rigid. It is stiff, not relaxing to receive the blood. So there is an impedance to the diastolic flow pan-diastole, because I'm going to later on differentiate it with constrictive pericarditis. So what happens in constrictive pericarditis? Because it is later in the diastole that the pericardium restricts the filling, okay? Because the pericardium is thickened and it is a fibrous case, so it only restricts when there is a significant amount of distension in the later part of the diastole. But here in this case, it is pan-diastolic. Remember, this will help you in understanding the physiology, right? So increased ventricular diastolic pressures and volumes, increased atrial filling pressures, pulmonary and systemic congestion leading to dyspnea or orthopnea. And that's why the patient will come with all these kind of symptoms, right? So it's a back heart, left-sided or right-sided, both may be involved, alone may be involved, all right? It should be differentiated with the hypertensive heart disease, restrictive heart disease of elderly, and CCP can produce a similar constrictive pericarditis can cause similar picture. So what are the causes? They can be myocardial, they can be endomyocardial. In endomyocardial, you have endomyocardial fibrosis, hypereosinophilic syndrome, carcinoid syndrome, radiation-induced anthracycline toxicity. Just keep all this in mind. And in non-infiltrative, you have scleroderma, diabetes, idiopathic familial. This is very important because now the drugs are available to treat amyloidosis. So this should be This should not be missed. This should always be in your mind that amyloidosis is a possibility whenever you're finding a restrictive physiology. I'm not going into the details because it's going to be very extensive and I may miss some important points. So we'll sometime later on deal with it. So what is the echocardiography? Most important, restrictive physiology. So as I said, when to suspect restrictive physiology and normal LV systolic function. Immediately RCMP should come into your mind. 2 steps. First, to determine whether echo features are consistent and try to establish the diagnosis. Final diagnosis is only through biopsy, and now cardiac MRI is very, very helpful in establishing the diagnosis. So what are the echo features? Normal size ventricles, normal EF, LVH, RVH may or may not be present, significant diastolic dysfunction, biatrial enlargement, mild MRTR, increased PA pressures, dilated IVC, there may be clots there, and the pericardium is normal. Again, remember, constrictive pericarditis is an important differential diagnosis of RCMP. So hence, I missed here, the pericardium is normal. So the grades of diastolic dysfunction. So all we know, twice, E wave twice. Again, in the pulmonary vein velocity, the atrial reversal is increasing in velocity, in duration. Okay. And see here, the tissue Doppler imaging. This is a systolic here. This is also dipping. It's not shown here well. This also dips down. Everything is dipping down. Okay, because of the stiff ventricle. IVC is dilated and non-collapsing. You do a sniff test. If the diameter does not reduce by 50%, we say that it is non-collapsing, meaning the pressures are really high, that the IVC is not able to hold back all that pressure changes. Less than 2.1, more than 2.1, this will be taught to you, and this is how we calculate the RA pressure as per the dimensions of the inferior vena cava. This is the opening into the RA, and this is a dilated IVC. See? Right? Because this helps us, because we will have to differentiate all the diseases wherein this kind of things happen. Now the hepatic vein Doppler restriction. Just remember a few things here. I'm not going to deal into detail. This all we know, and this is a respirometer which is connected, because we need to know what is inspiration and what is expiration. And this is the hepatic venous trace. This we know about. Okay, the mitral Doppler indices. And so what is happening here? This is the systolic flow. And why are these below the baseline? Because the hepatic vein flow comes like this. It comes down, all right, into the IVC. And let me see. So suppose this is the hepatic vein. Okay, so what will happen when you will put a Doppler here? So what happens? The hepatic vein drains into IVC and then here into the RA. Okay, so all the traces will come down and reversal will be up. Whenever there will be a back pressure from here, you will get a reversal. Okay, so have that concept that where is the blood flowing? Wait. So the blood is flowing down the hepatic vein into the IVC and RA. So you're getting them down. The major flows are below the baseline. Now reversals are, these are, normals, very little reversals. But in constrictive physiology and the restrictive physiology, they become bigger. Okay, because the blood is not being allowed to move forward because RV is stiff. So whenever there is a contraction of RA, what happens? The blood can't flow forward. So it goes back into the hepatic vein. And so that's how, see these reversals become bigger. Okay. So prominent flow reversals in inspiration increase both systolic and diastolic reversals. Okay, just remember this happens in inspiration here, and in constrictive pericarditis it happens during expiration. So this I have already told. Let me see. Okay, so this is the histopathology slide of amyloid deposition. Okay, so in between we have, this is amyloid. Okay, so among the normal myocyte, there's no myocyte hypertrophy in amyloidosis. Okay, there is no myocyte hypertrophy, only the amyloid is deposited in between the myocytes, causing distortion of the myocytes, thickening of the ventricle wall per se, but there's no hypertrophy. Remember, as in hypertrophic cardiomyopathy. So this is the difference. It mimics, but actually this falls into category of RCM. So remember these points which are related to amyloidosis, and whenever such kind of case comes, I'll show you some videos which will never allow you to miss on amyloidosis. So increased LV wall thickness, RV wall thickness, small, well or poorly contracting LV, depending on the stage of the amyloidosis. Enlarged LA, valves are also involved in this, both mitral and tricuspid, leading to regurgitations, usually mild. Then there is a thickened interatrial septum. All right. So generally to a tune of 5 millimeters. Diastolic dysfunction and pericardial effusion. This pericardial effusion again is not common in other causes, and whenever you get a pericardial effusion with such kind of features, always bring amyloidosis into your mind. See this now. You can never forget, this is amyloidosis heart. Amyloid heart. See this? And you can see this granular sparkling appearance. Not to be forgotten. See, both the atrias are dilated. LV is contracting so well. Okay. Biatrial enlargement. This is also called as owl's eye view. Okay, so both the atria are enlarged, and you will be wondering that what is it? Both RV is contracting well, this is contracting well, this is thickened, but then what is it? Now see this, this is a GLS view, bullseye view, where apical sparing is there. All the walls contract, there may be some problem with the other wall functioning, but the apex is usually spared, and this is a very characteristic sign of amyloidosis, that there is a bullseye apical sparing. See, this is a, there is a sign called as 555 sign in amyloidosis, wherein the systolic velocities, the E prime, the A prime, all are less than 5. Can you see this? Generally, they are present in the tune of 10. Okay, all of them are reduced because the muscle is diseased. It's not, the tissue is not moving well. So always remember, when such low velocities are there, there is a pathology of the myocardium. And as low as 5, think of amyloidosis. See the MRI. Okay, this is the LV, so thick, right? Both the atria are enlarged. Definite diagnosis is, of course, with biopsy. So I'll just, I think, let me skip this, else we'll miss on. See, in the acute active eosinophilic myocarditis, what you're seeing, there's an endocardial thickening, both biventricular. So you will have apical obliteration of RV as well as LV. So as I told you, in apical hypertrophic cardiomyopathy, this is a differential diagnosis. Okay, but it is rounded here. You will clearly see that apex is obliterated. But in that, the apex is clear like this. Apical HCM, Yamaguchi. But here the apex is obliterated. You will see some fibrotic component here. Now see this RV obliteration. Okay. And the biatrial enlargement. It is this can be very well visualized and assessed even just without even measuring anything. So again and again, I'm telling you, patient coming with heart failure, normal systolic function, biatrial enlargement, and restrictive physiology. Start thinking about restrictive cardiomyopathy. Again, this diagram, see this fibrotic obliteration of the apex, both the apices. Okay. Just know about it. In our territory, this is not very common, but there are certain areas where this kind of, in South and all, this kind of features are very, very commonly seen. Obliteration. See this obliteration, fibrotic obliteration. All granulomatous reactions are there due to hypereosinophilia and reactions resulting to that. Box and glove sign. See the whole apex is obliterated. This is an angiogram, LV angiogram. Be obliterated. It's looking like a small LV. The apex is gone. Now, this is the most important thing. Listen to it carefully because this may be asked to you again and again in your exam also, and will be a good thing to remember for your clinical practice. So restriction versus constriction. Here it is a muscle disease. It is a pericardial disease. Both result in restrictive physiology. Here the LV is non-compliant and stiff, but the pericardium is normal. Here it is reverse. The LV and IVS, they are normal, but the pericardium is stiff. There is no significant ventricular interdependence. Here there is a marked ventricular interdependence. This results in septal bounce, no septal bounce. Okay, here there is a significant respiratory variation in mitral valve and tricuspid inflow velocities. Okay, but not seen here. This is a septal bounce, which is, see, the septum is just bouncing because the RV increases, it dips down, the LV size decreases. When the RV decreases, the LV size increases. So there is a fixed cage, the fixed cage in which the LV has to fill itself, empty itself, fill itself, empty itself. So when RV increases, LV decreases, LV increases, RV decreases. And so as a result, the septum keeps bouncing. Okay? Because the pericardium is thickened and stiff, calcified. Now, the important things, wherein this kind of situation will come across you of constrictive pericarditis is, I'll just name 3 or 4 which will be very relevant for you to remember, is tuberculosis, is post-operative, any cardiac surgery has taken place, or post-tuberculosis, then post-radiation, right? So these are few things, which there is a huge list, but I think commonly you should, if you will remember this, you'll be most of the times able to catch it. Think about it that post-surgery patient has come up with heart failure, dilated IVC. Think that, am I dealing with constrictive pericarditis? And septal bounce is important, but not the sole sign. There are a lot of other signs, but septal bounce should always bring into your mind the physiology of constriction. Now, ventricular filling is restricted throughout diastole. As I said, pan-diastolic restriction is there. Here it is only during late diastole. So what is happening? Since the muscle is diseased, the E prime is less. And E upon E prime is abnormal because there is increased LV filling pressures. And remember this now. This is a very important thing to understand. In the tissue Doppler, these are all tissue Doppler imaging parameters. Okay, so when you will put a pulse wave Doppler on the medial annulus, E prime will almost invariably be more than 8. Okay, and generally what happens is when you do a tissue Doppler, the mitral prime is generally lesser than the lateral E prime, because lateral wall is a free wall and moves greater than the septal wall. All right. So the septal velocities are lesser than the lateral velocities. Now in constriction, a reverse thing happens, and that is called as annulus reversus. Remember this point because this is very important. Lateral E prime is less than medial A prime, which is normally not the case. This is the reverse case. So whenever you are finding such a thing, constriction should come into your mind. Why? Because the lateral wall is a free wall, and just outside it is is the pericardium. The pericardium gets fibrosed and get adhered to the lateral wall annulus, so it will restrict the movement of the lateral annulus. So what will happen as a result of that? The velocities will be lower and the medial velocities will rather be increased. So sometimes they say that if you are finding septal annulus velocities to be higher than 15, constriction should come into your mind. And here, why is E upon E prime less than 8? Because the LV filling pressures are not raised. Actually, it is the pericardium which is restricting the whole thing. So this is the difference. Here it is high, here it is low, normal. Atria is large. So these are all relative things. The pulmonary, the systolic pressures are high here also, but not that high. Here they are very high. And again, the longitudinal strain is less. Here there is no problem with the muscle. So the longitudinal strain is normal. Torsion is reduced because when the muscles rotate and circumferentially move, the pericardium does not allow them to move. Here the torsion is normal, but the strain, longitudinal strain due to primary muscle pathology, it is reduced. And the hepatic vein I have already discussed during inspiration, during expiration. So to sum up all these features of restrictive cardiomyopathy, you need to rule out pericardial disease, aortic stenosis, hypertension. This is the restrictive filling pattern, non-dilated ventricles, and hepatic vein reversal pattern during inspiration, biatrial enlargement. This never forget, biatrial enlargement. Just a second. Because you will not come across this in any other disease, right? So increased PA pressures, dilated IVC, and normal pericardium. Don't forget this. So thank you so much for your patience listening. I hope I'm able to make your concepts at least a bit clear that you are not going to miss it in the future. And rest, when you guys will come for the hands-on training program, you may, practice all this and keep revising and brushing so that do not miss. They are not uncommon. These cardiomyopathies are not uncommon once you look for them. Thank you.
All right, thank you, Dr. Hansa. Let's have some questions. I'm sure that everybody must be very tired. So, anybody has got a question?
Their mind must be in restriction.
No, it's a topic, like they have to put on all things together. Dr.
Yes.
Shantanu, go ahead. Dr. Shantanu, please go ahead, unmute yourself.
Yes, sir. Hi, sir. Thanks for the talk, ma'am. I just need to ask a simple question. How do you comment on the RA enlargement? Like we've talked of LA as of yet. I might have missed it, but can't really orient myself to the RA enlargement commenting on, sir.
Okay. So first of all, like, RA is generally smaller than LA. This you agree?
Yes, ma'am. Yes, definitely.
So in all these views, I'm showing you that RA is almost equal to LA.
Correct.
I told you about the owl's eye view.
Yes, indeed.
So first thing is that, the first view that you make, the 4C, and if you are able to see that both the chambers are looking enlarged and equal, almost equal, almost, right? So
Yes, ma'am. Yes, ma'am.
that will tell. So then there are other parameters of measuring RA also. Okay. So, I think 18 square meter, let me just tell you, because I really don't remember. I need to keep those parameters.
Right.
So
You measure a long axis and a short axis of an RA and divide by body surface area.
correct. So they are saying that RA area more than 18 centimeters square.
And then you trace the borders, get an area. These two methods will tell you whether RA is dilated or normal.
Okay. In the 4-chamber view, sir?
In 4-chamber. Rather
Four-chamber, yeah.
focused RVRA view.
Focus that. Okay, sir.
All right. Next one. There's one more person online. His name is Dr. Priya Singh. Priya Singh, go ahead.
Sir, please guide me why Valsalva method is required. Sometime when I do echo, the resting gradient less than 30, but in Valsalva, the gradient is coming more than 30. So what I consider, it is HOCM or it is not obstructive.
So a gradient of 30 and more is obstructive. So Valsalva maneuver is required when at rest, when you assess the LVOT gradient and you find them to be less than 30. So you will not just leave there. You will try to provoke the gradient. Why Valsalva is done is that you will provoke the gradient by reducing the LV cavity preload. So the cavity will become narrower, and maybe that the gradient gets aggravated, because whenever the gradient is high, it becomes an adverse prognostic marker. Okay, because when the patient will go and he will face certain circumstances, he will become symptomatic because of that gradient, which we did not provoke.
Okay.
So that's why Valsalva is mandatory, and never send your patient back without provoking the gradient if at all you are finding it to be less than 30. And when at rest and provocation, both you find them to be less than 30, then that is a non-obstructive hypertrophic cardiomyopathy.
Okay.
Right? And I told you another category which is latent. As in your case, you said less than 30 you found before at rest. But
Yes,
after
ma'am.
Valsalva, it went up. So it is a latent category.
Okay, ma'am. Okay.
Right?
Yes. Thank you, ma'am.
Yeah.
Second important thing, Priya, always whenever you look for hypertrophy, always try to do a Valsalva maneuvers. And Valsalva, what it does, it reduces a preload. So the LV cavity becomes smaller with reduction of preloads.
Okay, sir. Thank you, sir.
Right. Anybody with other questions? Dr. Mohara, go ahead, Dr. Mohara.
Good evening, madam and sir. So I have a question. What is the difference of hepatic venous Doppler in restrictive cardiomyopathy and in constrictive pericarditis?
Dr. Rakesh, you need to give this answer at this point of the day.
Okay, fine. I'll give you the answer.
Yeah.
Mohara, what you're asking is restrictive cardiomyopathy versus constrictive pericarditis, right?
Yes, sir. Hepatic venous Doppler.
Hepatic venous Doppler in constrictive pericarditis, first beat of expiration will show immediate reversal. In restrictive, it will not show. Why it happens? Because in constrictive pericarditis, the heart is covered in a shell of calcium. So, in normal circumstances, hepatic vein will always drain into IVC, systole or diastole. Does not make any difference. But when there's a constrictive pathophysiology, what will happen? When the patient inspire, a lot of blood will go from LA, RA to RV, and then the interventricular septum will bulge towards LV. As soon as the patient expires, uh, the interventricular septum bulges towards RV, and the blood flow reversal happens from hepatic vein, from IVC to hepatic veins,
Mm-hmm.
and that's how it happens.
Okay.
Doc, have you stopped sharing your slides? Good.
Yes.
Okay.
Yes.
So just give me a second. If you want this answer, just give me a second. I'll just show you like how you can really look at these things in a clinical practice. I'll just show you this. This is a very important thing to differentiate constrictive versus restrictive physiology. Give me 1 second. Let me open up my slides and then give you. And this is very good way of looking at hepatic vein Doppler in constrictive pericarditis. 103 slide. So let me just share my slides to you. You guys see my slides?
Yes, sir.
Okay. This is a patient with normal hepatic venous flow. Look at systole and diastole, both the times you are seeing still a constant flow from hepatic vein to IVC. Correct? And
Yes, sir.
there's a respiratogram. Look at this respiratogram also. First beat of expiration is still in other side. In constrictive pericarditis, when the septum bulges towards right side, the first beat of expiration reverses flow.
Yes.
And that is very pathognomonic sign of constrictive pericarditis.
Yes.
And I'll show you an example tomorrow. Like I can record and send you an example from my lab. Today we were recording effusive constrictive pericarditis from a young boy who was having recurrent development of pericardial effusion. Okay?
Okay.
And by the way, like one more things I'll just let me share with you. I see many people who are very intelligent in this group. They are not meant for basics. So those people who are really interested to learn this hepatic vein, DPDT, detailed evaluation of all valves, cardiomyopathy, we are holding this advanced skill training program 2025 from 14th to 17th April. And this program is a very important program. We do it every day, and we call them as Master the All of Advanced Acoustic Imaging Skills. And we try to demonstrate each and everything to everybody. And it's amazing. I'll send you everything on this. So that is what you can really learn if you want to do something. Like those people are very good in echocardiography. They are doing a good job. They can really learn these kind of modalities in 4 days of an advanced skill training. And the last day of this advanced skill training, we are holding another very important session. Give me a sec. I'll try to show you that important session also. This is what you can see the slides. what is that 25 years of celebration of Jorab Institute of Echocardiography? On 17th of August, we are holding this in Ashoka Hotel. And look, this is how the topics are. Advances in atrial fibrillation 2025. History, echo examination, debate, rate with this rhythm. Can we prevent atrial fibrillation in elderly populations? Advances in heart failure. Preserved, reduced, stage B heart failure, AMPA versus dapagliflozin. Then advances coronary disease, history and echo evaluations. TRIBATE, treating coronary disease medically, surgically, or interventions. And then we have a celebration for about an hour or so. Then mixed bag of full multimodality imaging cases. There are 6 of these participants are there. Multimodality imaging of CAD detection, stress echo, coronary CT. This topic has been modified to coronary CT versus MRI. What in 2025? Then nuclear scan. What scan in 2025? And the relevance of viability study in 2025. Last, very interesting session for advances in cardio-obstetrics. Echo changes in normal pregnancy, hypertension in pregnancy, diabetes in pregnancy, echo evaluation subject presenting with dyspnea, hypertension, palpitation. Can we predict cardiomyopathy in patient presenting with symptoms but a normal echocardiogram? Then peripartum cardiomyopathy and big nose to pregnancy, how to tackle it. Big nose is when not to get pregnant, and if you got pregnant, what to do with that. So this is what we are thinking. We have already planned it. Everything is done. All speakers are done. And that's what we are contemplating to have this particular program on 17th of August. And as far as the other program is concerned, I'll just share you the list of our topics for those people anybody who wants to attend this particular program. We do it every year, once in a year, not more than that, because not possible, because we'll be collecting all cases for presentation during that time. And we have already started collecting cases. It's only once in a year. Look, this is on 14th August. LV systolic functions, basics. Then advances in LV systolic functions. Then echocardiography of right heart pressures. Basic and advances. Diastolic functions, including LA strains. Echo in acute coronary syndromes. Echo in cardiomyopathy. Then next day we start with mitral and tricuspid stenosis. Next is aortic and pulmonic stenosis. We go up to date. Valvular regurgitation lesions. And lastly, multivalvular lesions. How does they affect one with each other? Then introduction of 3 dimensions echo, transthoracic. 16th, we are having in the morning a digital stress echo. Then 2D, 3D and Doppler assessment of normal and dysfunctional prostatic valve. What the newer guideline says in 2025. Hypertrophic obstructive is a separate topic altogether. What she taught today was amazing. Then role of echo in heart failure. All what you need to know. And finally, echocardiographic dilemma of pericardial effusion, effusive constrictive pericarditis versus restrictive cardiomyopathy. And then we close down and move on to 17th in a Ashoka Hotel for our 25 years celebration, along with excellent symposium. And believe my words, all the possible best speakers and practical clinical echocardiography is available for learning purposes. So I'll stop over here and quickly take your attendance. And I have noted down many people who have already done this. And before that, let me pay thanks to Dr. Hansa Gupta. Dr. Hansa, thank you very much for being over here. And
thank you for inviting me.
Almost 2.25 hours for excellent deliberations.
Thank you so much.
Thanks a lot. And you may disconnect now, and I'll just...
All right.